So, get started. Okay, so we have a 63-year-old female who has a history of floaters and vision loss several years ago. Who presents for the similar symptoms in the same eye. In the past, she had elevated IOP and took some steroids, as well as some other medication, and says that the eye got better. With this most recent episode, she said it started about 2 months ago with floaters and progressive blurry vision. She has a history of amblyopia, and her left eye is her good eye. Her past medical history, non-contributory. Her visual acuity in that right eye is poor, maybe at baseline. And then in that left eye, her good eye, it was 20/50 at distance and 2400 at near. Her pressures are normal.
All right, so can you hear me? I can't tell.
Yeah, sound good, actually.
Okay. So this is a color fundus photo of the right eye. The vitreous, the media looks pretty clear to me. The nerve looks sharp. Pink looks distinct, normal cup to disc, probably like a 0.2. You have a little bit of a temporal PPA or a little crescent. And then vessels look normal caliper, not too tortuous. And macula looks normal foveal reflex. I don't see any exudates, any drusen. Everything looks pretty good, at least from what I'm seeing here.
Right. Okay.
Is there an artifact at the very bottom?
Yeah.
Jesus. Yeah, that's right on my out.
Okay, and so then this is color fundus photo of the left eye. Very obvious, hazy media. You can't really make out. It just seems mostly like it's the media that's causing the obscuration of the retina. I can't really tell beyond that where the pathology lies. You see a blurry nerve. You can see centrally there's more of it's more blurred central around and peripapillary, whereas you do get a little bit more definition to the vessels and as you extend out to the periphery. Yeah, I don't, maybe something in the macula, like a little spot of hyperpigmentation. I don't know.
How about supratemporal? It looks like there might be something in the retina.
Supratemporal.
It's kind of white. Does it look when that one spot is?
Yes.
Oh,
Yeah.
like at the very, you're saying like at the very end of the superior. Okay, yeah. Yeah, so one small creamier white sort of compared to the rest of the fundus that you're circling there where the vessel splits.
Might be, the view's not great, so it might be just a shadow, but it might be something, especially if there's
It's like this little granular area down in her temple.
yeah, there might be a little spot over here.
Yeah.
Maybe.
Yeah, I could, yeah, if I blur my vision a little bit, I could say that. Yeah, I'm squinting. Yeah, I don't know. I can't get much out of this just with the blurred view.
And we're gonna get a magnified.
Oh.
Okay. And this is, where was this? This was
This looks like it's infranasal. Where is this in the?
nasal. Yeah, I didn't see this in the original photo.
Yeah, this wasn't the original picture.
Okay. So I see a much more distinct photo of this whitened lesion with spots of surrounding hyperpigmentation, some throughout the lesion as well as along the borders of it. Doesn't look like that. You can maybe see a little bit of choroidal vessels below it or some sort of vessels within it. Yeah, I don't know much more.
Good. Well, go ahead a little more. So does it look like there's sort of two components to it, this lesion, if you look at the whole?
Yeah, to me, it looks like the one kind of to the left in our view looks a little bit more anterior to us. It looks more kind of raised, whereas you have the other one looks a little less distinct. It looks more posterior, at least to me.
So does one look chronic and one look more acute?
Yeah, so from, just the hyperpigmentation, I would say that would be more of a chronic sort of lesion, whereas the fainter, so the one on the left would be more chronic, and then the one more on the right would be more acute.
Yeah, perfect. So it's sort of scarring. Pigment in the eye almost always means chronicity. Like around a detachment, if you have a nevus with pigment, or if you have pigment's generally a chronic thing.
I think we have one more magnified view.
And then you start seeing the cells.
Yeah, so kind of showing the same lesion. Oh, yeah, same lesion there, but it looks like a little bit more hazy picture of it. It'd be picking up some of that vitreous debris. All right, so this is an OCT MAC. You see, it looks like there's some sort of a epiretinal membrane on the surface over the fovea, as well as the vitreous has quite a bit of debris in it, or cells.
Some of that's just exposures. This snow is probably just a function of the settings on the machine, but these white spots probably are actual vitritis, probably. But this is probably just, the image quality, all that snow. Okay, go ahead.
Can't tell if it's just the photo, but I don't have my inner retinal layers don't look all that distinct. Outer retinal layers look a little bit better. I can make out the photoreceptors, bands. I can make out all three, RPE and Brooks complex there. You do have on the, looks like, on the temporal portion of the fovea, you have like a little bit of a cavitation, or from the epiretinal membrane, or some fluid. Corey, you don't have much. Oh, go ahead.
What about that thing where the arrow is?
I don't see an arrow. Oh,
Can you see the arrow?
yeah, I can see it now.
Okay.
Yeah, just like a raised spot along the, attached to the ILM, but I don't know what it would be. Just like a little
Deposit. I mean, given the vitreous, you saw all that junk in the vitreous, but there's probably
so
just
maybe a clump of cells or some sort of deposit that's sitting on the surface of the retina.
Yeah, I thought the retinal layers were pretty kind of well organized, not disrupted.
Pretty good.
Mhm.
There's no macular edema. With most of these inflamed eyes, presuming it's inflammation, you're mostly looking to make sure it's not macular edema. And then the rest of it's just sort of funny looking,
Okay, and then this is and so then there's another OCT MAC, and the vitreous, again, can't tell if it's exposure or if those kind of do look more like truly cells. Now that I'm looking, looks like there is some of those deposits along the surface of the retina there, again with an ILM, or sorry, with a epiretinal membrane. The rest of the retinal layers look organized. And then
I mean, it's all pictures.
Mhm. Just kind of summarizing the findings. So do you have any differential diagnosis?
You can do the summary. So,
So 66-year-old female, history of floaters and progressive blurry vision that resolved and now presenting with the same kind of symptoms for the past 2 months. And then so I said there's a, for the color fundus photo, a fluffy white lesion next to the larger kind of scar, chorioretinal scar with possibly some overlying vitreous haze. And then for the OCT, the hyperreflective spots in the vitreous, the ERM, and otherwise kind of the retinal layers are pretty well organized.
Good, very nice, thank you.
Mhm.
Yeah, so for my differential, my number one would probably be like a toxo, or some other, or it could be like ARN or porn or some other uveitic process, syphilis, histo, just like a histo spot. I don't know, but I would say my top would be toxo.
Very nice, good.
Yeah. And then you could also consider some autoimmune stuff as well, Behçet's and retinal vasculitis. So our patient had recurrent ocular toxoplasmosis. So this organism is a single-celled obligate intracellular protozoan. The definitive host is the cats, but we are the intermediate host as well as other mammals like livestock and birds. It's the most common cause of posterior uveitis worldwide, and it's thought to like at least like a quarter to a third of the world's population may be infected by toxo, though this varies greatly by region. So in the US.
Deer, for venison.
Oh, deer,
Yeah,
okay.
because I've the last couple of years, I've seen a bunch of people with primary toxo from eating venison, undercooked venison.
So for stats in the US, I saw that the prevalence is about like 20% with up to 2% developing ocular kind of manifestations of toxo. In Brazil, I saw that this ranges from 40 to 80% prevalence and up to 20%.
It's very, very nice.
Are you from Brazil?
Yeah, we see that a lot of.
Oh, yeah, all the good studies are out of Brazil.
Seems they got cats, bro.
What's the reason?
I think like food, like not very good access to clean water
Okay.
and, yeah.
Mhm. We kind of throw back to step one stuff. So, the toxo organism has a very
That could be
bad.
on ships.
Interesting to me. So it exists in three forms. All three forms are potentially infectious. So the oocyst is like the egg or the spore that replicates within the GI system of cats. And it's shed through their feces, contaminates soil and water. And then when the intermediate host consume that, it activates it into this adult kind of tachyzoite infectious form that can enter the bloodstream and spread to tissues like your eyes. In a healthy host, you can destroy most of these tachyzoites, but some of them might be walled off by these cysts where they can remain dormant for long periods of time. And so common risk factors for infection are consumption of raw or undercooked meat like pork, unwashed produce, unpasteurized milk, and like contact with infected cats. And so I just wanted to touch briefly on congenital toxo because the rest of the presentation is mostly on acquired toxoplasmosis. So it's originally believed to be the most common cause of ocular toxo, but recent evidence shows that most cases are acquired. Up to a half of infants will develop congenital systemic toxo in mothers who were newly infected during their pregnancy. And a majority of them do develop ocular disease. And the risk of infection is higher later in pregnancy, but if they were infected earlier in the prenatal period, it's associated with more severe disease presentation. And so in med school, we kind of learn about Sabin's tetrad, I remember as the 4 C's. So chorioretinitis, hydrocephaly, intracranial calcifications, and cognitive impairment.
Is there anything done in Brazil to try to watch out for pregnancy and toxo? Anything specific, because it's so common?
So it's for pregnant women,
Yeah.
we do the toxo test as a routine.
Okay,
I don't think we do that here. do we?
no.
We do that as a routine.
I heard something, you don't try to infect girls when they're younger, before they're pregnant, do you?
No.
Okay, I heard a story about that, like they used to do that in the old days with rubella, before the vaccine, they do parties. Where you, yeah, before,
Pretty benign, other than the eyes.
Yeah. it doesn't make such a difference, okay.
No.
It is, but not.
And the other thing I've had, which is interesting on your congenital slide, I had one patient I had years ago with congenital toxo, came in and she just had a brain biopsy because somebody's worried about metastatic cancer in her brain, and I'm 99% sure it was the calcifications. So when I see congenital toxin, I warn them someday someone might want to do a brain biopsy on you and just tell them that you have congenital toxin.
Oh.
So, common symptoms typically associated with vitritis, so floaters, blurry vision. If they have anterior uveitis, they might have some eye pain and redness. They might have some CNS involvement if they're like immunocompromised. So they might have focal neurologic deficits, cranial nerve palsies, visual field loss. And the classic finding is this headlight in a fog, which is pathognomonic for toxo. So it refers to this very like active hot white lesion with overlying vitritis that obscures the lesion. And typically you will see a satellite lesion. So a new white lesion next to an old scar, because the bradyzoites, they remain dormant, like at or near the edge of those old scars and reactivate there. Toxo is also one of the infectious causes of uveitis that can cause elevated IOP. If it's near a vessel, it can cause retinal vasculitis, as well as some uveitic symptoms as well, and some signs. So atypical findings would be lack of a scar, if there isn't a lot of vitreous inflammation, if they have several or bilateral lesions, papillitis, neuroretinitis. I also read about this Chorioretinitis, which I thought was like an interesting phenomenon. It's like associated with severe inflammation, but you have these multifocal kind of white plaques along the arteries. As well as punctate outer retinitis, which are described as having these small punched out lesions along the periphery. The 5-year recurrence rate is about 40 to 80%, and the highest rate of recurrence is within that first year after infection. So I have a picture of Chorioretinitis arteritis. So you see this vessel here, and it also like almost has this skip lesion of these white plaques along the vessel. So toxo is a clinical diagnosis, but you can use serology testing, IgM and IgG. IgM, I think, persists only for about a year, whereas IgG is lifelong. So if you have like a healthy host, if they're negative for IgG, you can almost certainly rule out toxo, also PCR, and then you can use OCT to kind of corroborate your diagnosis. And I have some interesting or descriptive illustrations here. So for an active lesion, you will see thickening of the retina with this full thickness hyperreflectivity. You can see it extends all the way down to RP and breadth here, and then some posterior vitreous cell here along the top. And in the chronic phase, you will see resolution of that hyperreflective area. You'll see some atrophy, and then here you see some posterior highlight thickening as well as the ER inflammation with the chronic inflammation. And then this just demonstrates the PVD with the thickened posterior highlight base. So there's no consensus on treatment for toxo, and really the goal isn't to eradicate the disease, but to decrease the duration of the active infection. It's typically self-limiting in healthy hosts. It'll resolve in about 4 to 8 weeks is what I read. But if they have large or several lesions, if it's near the macula or the nerve, if they have dense vitritis that causes significant decrease in vision, or persistent lesions, you might want to treat it. And absolute indications would be if they're immunocompromised or they're pregnant with new infection. And so the classic triple therapy that we typically learn about is the pyrimethamine, sulfadiazine, and prednisone. Quadruple therapy is the above plus clindamycin. But I think pyrimethamine and sulfadiazine is like very hard to get and very expensive. So there have been some studies that showed that Bactrim or azithromycin is just as effective. You could also consider intravitreal clindamycin with some short-acting steroids, and then some topical drops for the anterior uveitis symptoms. And so patients with recurrent, frequent recurrence, they may benefit from long-term maintenance therapy. And so one small study showed that Bactrim prophylaxis can significantly decrease recurrence rates within like a 20-month period.
There was a really good study out of Brazil in the AJO years ago where they had Bactrim every other day
Yeah, 3 times a week.
for 5 years or 7 years. It had almost no recurrence.
Yeah.
It was it was an excellent study.
It's like Monday, Wednesdays and Friday, you give like 1 Bactrim, so 3 times.
And you do it for a couple of years, right? Yeah.
So what do you do with pregnant women that test positive?
That's what I was wondering. What do you do with the pregnant woman? I would think testing negative would be worse. So if you test the pregnant woman, for toxin.
And if it's IgG positive, that's
Okay,
good, that's great.
Yeah.
okay.
But if it's IgM positive,
Oh,
then you have to do all the treatment to
okay.
prevent congenital toxoplasma.
Right.
Okay, that
For
makes
that.
sense. And if they're negative, you just tell them to be super careful. Or positive.
So yeah, if they are IgG negative,
Yeah,
you have to warn them to be super careful with what they eat.
Yeah,
And then you test the first and second and
I
third
was gonna say you
trimester.
must test
So you test 3 times,
periodically,
yeah.
right, okay.
When I got pregnant, I was excited to be, I wanted to be IgG positive, but I wasn't,
Oh.
so I had to be really careful.
So you should get a cat before you plan
That's
on
what
having
I'm kid.
before your pre-pregnancy planning is
Yeah.
getting a
Yeah.
cat.
So visual prognosis, obviously largely dependent on the location of the infection, the severity of the inflammation, and the subsequent complications related to the inflammation. You want close follow-up because early identification and treatment can often lead to better visual prognosis. And I also read that like intraocular surgery can actually reactivate the Brady's zoite, so you may want to consider prophylactic treatment prior to surgery.
right.
Have you ever not treated toxo?
Yeah.
Yeah.
Yeah, anything outside the arcades, I
You don't treat?
just let it go. And then I had a patient, I think we presented here, who had a young guy, a parafoveal acute primary toxo. And I was like, oh God, what do I do with that? And I'd send a bunch of random people, just Bactrim. Everybody said Bactrim.
Yeah.
So I was wondering, like, if it's that close to the fovea, do you inject with clindamycin or any other
You
questions?
find
on
it
toxo?
steroid after you start the methodic.
Yeah,
We just had a similar one and I had Dr. Ashi
Yeah.
sit with us. He came through.
for a parafoveal.
He was referred, for concern of iron,
Okay,
but he had it was inside the arcade, retinal chorioretinitis, and he was on Valtrex already when he came. So we tested for, iron was negative, and then when I saw him, we tested for toxo, he was IgG positive, and then we did PCR for toxo, was positive, was the first uveitis event, so we started him on Bactrim, and because it was so close to the fovea, now he's on steroid also.
you did, okay. There's nothing fancy, I think that's good. All right,